Chronic obstructive pulmonary diseases are a group of pathological conditions defined by a chronic, complete, or partial obstruction to airflow. This blockage can manifest at any level of the respiratory tract, from the trachea down to the smallest airways. Because the damage is structural, it leads to a permanent disability of the lungs. To understand why this obstruction becomes permanent, we must first trace the sequence of the airway and the specific layers of its walls. Respiration follows a strict anatomical sequence, beginning at the nose and descending through the pharynx and the larynx. The path continues into the trachea, which then splits into the primary and secondary bronchus. From these larger pipes, the network branches into the microscopic first, second, and third degree bronchioles. This leads to the terminal bronchiole, the final segment of the conducting airway, and then the respiratory bronchiole. Finally, the air reaches the site of gas exchange, the alveolar ducts, and the alveolar sac. This 10-step hierarchy ensures air reaches the blood, but it also provides a massive internal surface area where microscopic obstructions can take hold. Every airway in this sequence is built from 4 layers. The innermost is the mucosa, or epithelium, followed by the submucosa, which contains the airway's glands and serous cells. Support is provided by the muscularis propria, containing cartilage, and the outermost layer, the adventitia. These airways are also interconnected by bypass channels. The channels of Martin allow air to move between adjacent bronchioles. The canals of Lambert connect a bronchiole to an alveolus, while the pores of Kohn allow adjacent alveolar sacs to communicate. These 4 layers and 3 collateral channels represent the normal respiratory architecture, the very structures that chronic bronchitis begins to dismantle. Chronic bronchitis is diagnosed clinically as a persistent cough with expectoration on most days for at least 3 months of the year, occurring for 2 or more consecutive years. This condition is most frequently observed in middle-aged males. The cough is driven by an oversecretion of mucus, caused by an increase in the number and size of the submucosal glands in the trachea and bronchi. This cellular adaptation, the physical expansion of the glandular layer, converts a temporary irritation into a chronic structural pathology. Smoking serves as the primary etiological trigger for this glandular expansion. Atmospheric pollution provides a secondary source of chronic irritation. Occupational hazards also play a significant role, particularly in environments like cotton mills, where workers inhale high concentrations of fine particulates. Exposure in plastic factories and recurring respiratory infections can also initiate the disease state. Regardless of the source, the human lung responds to these external irritants through a specific, destructive pathogenic sequence. We can trace this cascade starting with the act of smoking. The inhaled irritants cause immediate inflammation in the trachea and bronchi. This irritation stimulates the submucosal glands. In response to the chronic stress, these glands undergo hypertrophy and hyperplasia. This cellular growth leads to a measurable increase in both the size and the total number of individual glands. This expanded glandular network secretes an excessive volume of mucus directly into the airway lumen. This creates a physical obstruction in the trachea, resulting in breathing difficulty and a persistent cough as the body attempts to clear the sputum. In this context, the chronic cough functions as a failing mechanical reflex to clear a structurally compromised airway. At a macroscopic level, the bronchial wall appears thickened, hyperemic, and edematous. Within the lumina of the bronchi and bronchioles, we find physical blockages comprised of thick mucus plugs and purulent exudate. These gross findings are the direct result of the submucosal hypertrophy described earlier. To categorize the severity of this tissue change, pathologists utilize a specific mathematical ratio. This metric is the Reed index, defined as the ratio of B to A. Variable B represents the thickness of the submucosal mucus glands, while A represents the total thickness of the bronchial wall. An increased Reed index provides quantifiable evidence of the glandular expansion. This ratio confirms that the airway has undergone a permanent structural transformation. Looking closer at the tissue, we see a marked increase in goblet cells, which further contributes to mucus production. The bronchial epithelium itself shows signs of squamous metaplasia and dysplasia. Notably, these changes occur with very little chronic inflammatory cell infiltration. These microscopic changes, from goblet cell proliferation to epithelial metaplasia, define the underlying pathology of chronic airflow obstruction.